I'm Ozana Moraru, and I'm going to talk about retinal detachment after phakic lens implantation risk and management. First of all, I want to thank to the organizers, Professor Tonieto, for inviting me here. There are several ways of surgically treating the high myopia. There are corneal refractive procedures and intraocular refractive procedures. The first group, we eliminated it because of the high risk of corneal ectasia, and what we do intraocular refractive procedures, either phakic lens, which keeps the natural lens in accommodation and is recommended in younger patients, or lens-based surgeries, refractive lens exchange, which is recommended in presbyopic age patients. Of course, like in any surgery, there can be complications. The topic for today is the retinal detachment in these cases, and we analyze a bit if it is a direct relationship between our surgery with refractive lens implantation and the retinal detachment itself. I'm going to present you a few cases. This is a lady with myopia -8 who had 10 years prior to come to us a refractive surgery in another country. She has implanted an ICL, and she developed cataract after several dislocations of this ICL and several attempts to reposition it. As you see, the removal of the ICL is quite difficult because it's a soft material, difficult to grasp it. Eventually, we cut it in two. It's quite a large lens, and we perform a 2-point incision on the most refractive meridian. And then we proceed with the cataract extraction. 1 year later, she came to us with a rheumatogenic retinal detachment, as you see here. And of course, we needed to proceed with the surgery. We performed 25 gauge parsplanal vitrectomy and the laser gas tamponade. The most challenging part of the VR surgery was this very attached hyaloid on a totally detached retina, but we managed to do it very well with a diamantino scraper. After we did this on 360 degrees, we stabilized the posterior segment with perfluorocarbon, and then we can continue further on with our standard procedure. We have some question: what was the cause or risk of the RD? Is it the ICL surgery, the numerous attempts to center the ICL, the cataract surgery, the myopic status itself? As you can see, this lady had a lot of peripheral dystrophic retinal areas. The next case, it's a presbyopic female as well with high myopia, -11, in which we implanted 6 years before an Artiflex IOL. Again, this is, and she developed cataract, retinal detachment, not cataract. We need to explant this soft IOL and then to continue with the cataract surgery. We just needed to put on a suture on the 3.2 millimeter incision through which we removed the Artiflex, and then we continue with the PPV for the retinal detachment. Again, these are young patients. Most of them do have attached hyaloid. We had the same problem, but we continued and we did the same maneuvers for dealing with attached hyaloid and on the totally retinal detachment. This lady finished by having a good visual acuity, 20/40. And again, we have the same question: which was the cause? Is there any relationship between our surgery done 6 years before and the retinal detachment that she presented with today? This is the third case. Again, a presbyopic lady with a high myopia, -15, for which we implanted an artisan, not foldable, refractive lens. This is easier to be explanted because it's PMMA, so easier to be grasped, but unfortunately we need an enlargement of the incision, and you can do this incision 6 millimeters either limbal, but you need to suture it, of course, with several sutures, or scleral, in scleral tunnel. And the other difficult part of the surgery is the phacoemulsification itself, because as you can see, there is leakage that you have. So if it was a less experienced surgeon or the cataract was worse, more complicated, I would suggest to perform another incision for the phacoemulsification, another 2.2 millimeters in another place, to avoid this leakage. Eventually, I had, of course, to suture not only the incision but also the paracentesis, because on this high myopia, the sclera is very thin, and you need to be sure that you will not lose the anterior chamber or flatten during the indentation, during the PPV. This lady also finished by having an incredible detached visual acuity at the end, and again we have the same questions, if there is a relationship. between this retinal detachment. Some other case presentation: myopia 14 diopters operated 20 years prior, a young lady operated again 5 years prior, another one 20 years prior to come to us. The international literature is, you can find several articles which helped us in making some conclusions, which are based on literature and our own limited experience. Apart from one study which I found to have 7.2% of risk, all the other studies show less than 2% of risk of eyes operated with phakic refractive lenses who develop retinal detachment. It is the same prevalence of RD like in non-operated high myopic eyes. So it seems there is no direct cause of risk for retinal detachment produced by the implantation of phakic refractive lens. There is no significant differences between posterior phakic lenses, ICL, and anterior chamber phakic lenses, tip iris claw type, although there was a study who showed 0 in iris claw type. In terms of surgical technique, either you can do alone pars pala vitrectomy or combine pars pala vitrectomy with refractive IOL removal and phaco, but the patient seems to choose the concurrent procedures because it is more comfortable for them to have all in one. And in combined procedures, and as I mentioned, PPV is more or less standard technique, but the phakic IOL removal can be challenging. If it is foldable, it is soft and slippery, difficult to remove. If it is non-foldable, it's easier to remove, but you need larger incisions and sutures, and you have to deal with the astigmatism afterwards. And again, the main incision for the phacoemulsification can be challenging because you can have leakage. Anyway, clinical results are very good, anatomical and functional, both in our experience and in the international literature. Thank you very much.
Thank you, Ozana. Let me present Frank Eckhoff.